I think I enjoy Alan's talk. You know, I would rather give my 40 minutes to you. Although now I have only 30, but
I'm sorry.
no. Alan's talk actually take us to a place where knowledge are standardized, or medical knowledge is standardized, transferable, and actually amplifiable. So that will be the kind of future that we would like. So when we talk about precision medicine, just do all these. Automatically, we were reminded that there's another movement called artificial intelligence, or AI, right? AI are interpreted as artificial intelligence, or sometimes, as I was talking in the IBM forum yesterday, they call it augmented intelligence. So not necessarily stands for artificial, but rather for augmented. In that case, then this, robot killing human and rule the earth scenario will not be happening because it's just augmented. Okay, anyway, so if you believe it, it's a very big market, from 55 trillion to 50 trillion market, and people are going to lose their job and things like that, right? And among people who's going to lose their job, physicians. But the funny thing is, I've been in other talks, and they're actually picking the type of physicians that's going to lose their job first. Among them, radiologists, unfortunately. Okay, if you're thinking of a career in radiology, maybe you want to think again. And also, everybody who's reading picture as a living will be replaced for like the first row of people losing job, like pathologists. If their job is just going to read the picture. But on the other hand, if we look at this as an augmented intelligence point of view, people are going to do their job very easily, right? So a radiologist would go to work and just press one button, and they can, and then sign everything, right? And then he can have a vacation. So it may not be too bad. Okay. AI is actually this traditional definition of AI is when a machine mimics cognitive function. So people also call it cognitive science or things like that. Cognitive machine. There are many different terms. And among many of the cognitive functions, the most mentioned are learning and problem solving. Okay, so these are the definition of AI. I like to use this slide because one of my professor when I was in the U.S., when he started to teach us AI, he started with, we don't need artificial intelligence if we don't have natural stupidity. Okay, so. But again, that happens, again, it's been proven again and again, humans make errors unconsciously, right? And sometimes continuously without regret, because they don't know. So how do they, without regret? So anyway, and we have this natural stupidity defense system, so we shoot a missile and then we hit a fishing boat, quite accurately. And a lot of people die. So you've all heard about medical error and how bad they are, right? So now this is not the new number. New number is 250,000 patients. After we've been doing this since year 2000, so we've been doing patient safety, reducing medical error for 17 years, and now we have advanced medical error as the top, cause of death from number 4 to number 3. Okay, and we have increased the number of people killed by medical errors from 100,000 to 250,000. So what happened? What happened to people, or doctors, and among other medical professionals? There are just too many medical errors, and we have inconsistent quality, and we typically use one-size-fits-all approach. That is, of course, the opposite of precision medicine, but actually that's what we're doing today, right? So this is the old Gilbert cartoon. He said, oh, it seems like we have a mix-up error test. So Gilbert said, oh, so then I'm not dying. Doctor says, well, doctors are amazingly smart. I agree, yeah. But occasionally we make a little error. And then oh, deeper say, I understand. The doctor says, by the way, your pap smear was normal. Okay, so that's what doctors do. And we don't have good quality. New England medicine tends to, journal medicine tend to tell us that 50% of the people do not receive good quality care. And it's become a leading cause of death, and it's more common than we thought. It's a system problem, and it's very expensive. And people are thinking that 50% are preventable because they're a large study. But preventable by what? Preventable by double checking, triple checking, having 2 nurses do every job, having 3 physicians, talking to each other before surgery. I don't think that's the way that we're going to prevent medical errors, right? So I think AI is the potential answer to this type of medical problems. Okay, so this is another thing. It's a new drug that cost about $500,000. It's called Temporal. It's actually not a drug, but it looks like a drug, but it's actually not a drug. It's your own WB, its own white blood cell, right? And it's extracted and amplified and put it back to people. So this $500,000 drugs, there are 3 innovations actually. First, it's not a drug, but it's called a drug. So that's the first innovation. Second is, it's very expensive. There's no drug that would cost $500,000 US. And the third innovation is that if it doesn't work, you don't have to pay. Okay? So they're making big bet. These big pharmas, they're making very big bet on these type of new treatment. So that brings us to the precision medicine age, right? So in this, we used to call something personalized medicine, and then we moved to precision medicine. But in a precision medicine initiative, there's a way that we should care not just the biological system, but more on the lifestyle and behavior. So it's environment, lifestyle, and genes all has the same importance. So now I used to have a model saying that these are the 5 type of data that we should look at when we're doing patient safety or preventing medical errors. We need patient profile, we need diagnosis, we need procedures, medications, and lab, right? But then, if we look at all these 5 elements in a time dimension, we actually need all the data from birth to now, plus genomic data, exposomic data, that means all the exposure factors together, right? It's a new word. It hasn't stick yet, but I think I like this term called exposome, right? And then exposotype, exposomic, right? And behavioral data. So these are the 3 cornerstones that's going to actually define and drive precision medicine. So it's not just more understanding into the genomic data. It's also, and actually there are people claiming that genomic data actually only contribute to health condition, about 20% of the health conditions. So even a twin with exactly or almost identical genomic composition, one smoke for 30 years, the other don't smoke. Apparently they will not have the same health condition after 30 years. So behavior apparently is very important. And giving the same twin, one live in Beijing and the other live in Taipei or Michigan, Ann Arbor, I think their respiratory system will be very different after 30 years. So environment is also very important. So when we again leave the cloud and come back to Earth, and we look at what's happening in our current practice of medicine, we have a diagnostic accuracy of about 80%. 20% of the time, based on a big study called the Human Diagnosis Project, 20% of the time the diagnoses are wrong. And what are the doctors doing? Are they stupid, or what happened to the doctors? Or medical school actually make you dumb? That's true, but We're not this dumb, right? Okay. So what happened? Why is this? But when you look at another study, it tells you that when a doctor is making a diagnosis, 75% of the time the information are not complete. Meaning, most of the time they don't have enough information to make a decision. So 80% right is not that bad when you consider that, right? Okay, so, and we use a lab data range. You know, imagine if you all have your health checkup, right? 有做过健检的举手一下，都有啊。OK， 上面有红字的举手一下。OK， 情况下 ，OK， so if you do a health checkup and your GOT, your liver function is more than 40, you get a red number. Okay, so 41 is red. But if you're 39, it's black. Black's good, right? You want your health checkup report to be just black, no red, like your transcript or score, right? But then as we get older, we get 1 red and 2 red, and then suddenly it's like 50% red or mostly red. But again, is that a correct range for all of us? You know, so if you're a 10-year girl versus a 80-year-old man, should we use the same lab range? You know, 41 is red and 39 is black? Of course not. I mean, no one in their right mind would think that we're doing the right job right now. Right? No wonder it's not good. No wonder the health quality is not good. We're not actually doing what we should be doing, which is a more precision or precise or personalized lab range. Right? We're not even distinguish, you know, age and, well, the only part is like in hemoglobin, there's there's slightly different range for female and male. That's it. Out of the 8,000 lab tests and lab range, we only have one that distinguished male and female. And if we look at the allergy information, we've done a very large scale study. 40% of the allergy information are missing. They're not in the electronic health record. And out of the 60% that has something, we look at them, another 40% are gibberish. I mean, they're just A, B, C, those things that doesn't make sense. So a lot of information are not there. And family history are almost non-existent. Or when it exists, it's not accurate at all, right? Because when you're facing a patient, you're asking, how does your grandmother die? He will say, I don't even remember when she died, right? And you have to tell the doctor, you know, 40 years ago how did she die? So that's very difficult. And so we're talking about genetic, behavior, and environmental data, and it's all not available. I mean, all of them are not available to the doctor. Okay, so there are projects that's helping us getting all this data and their tools, right? IoT and all this wearable device, that's going to get all the data you want. So once we have all the data we need and all the data we want, who's going to read it? Okay, so if a patient comes to you and tell you, no, I'm a doctor, so they should come to me and tell me, here's a USB and the heart rate, my heart rate in the past 365 days. So please read it. Now who's gonna read it? I'm going to have to close my shop and then read the whole thing and then tell him, I don't know what happened, you know, after reading 365 days of ECG. Okay, so once you have the data, you have the human overloaded. Okay, not just they don't have the time to read it. Even if they have the time to read it, they might not make sense out of this huge amount of data. And if we really spend a lot of people reading it, who's going to pay for it? Okay, so my take on this is that precision medicine, if not helped properly by technology, will be just something for the richest people in the world. You know, most other people like us, we're not going to enjoy what precision medicine will bring to us because it's too expensive. Nobody can afford it, right? So if we don't, at this moment, if we don't bring the right technology, like knowledge grade, and AI in general, we're not going to have it at all. We don't even have to talk about it. It's not going to happen, right? Okay, so AI is doing some job to help it. So we're going to need background lifetime data surveillance, smart summarization and visualization, just-in-time diagnosis. I like the knowledge object because it does late binding and just-in-time learning, right? So when you need it, you get helped. And treatment advice, disease prediction, as many of you have been talking about, prevention and early intervention. And these all rely on how we deliver the logic intelligently to the clinical setting. And knowledge creep is one of the mechanisms that we like. On quality and patient safety, also, we need background patient data surveillance, real-time cross-checking and reminders, adverse events, identification, prevention, prediction, and prevention. I mean, if you cannot predict, you cannot prevent, right? General, indifferent, one-size-fits-all prevention usually don't work, right? It usually doesn't work. If we tell everybody you have to eat 5 kinds of vegetable, exercise 40 minutes per day, and and do this and do that for everyone, that doesn't work. Because everyone don't think they have the same risk, and everyone doesn't have the same risk. So we have to actually stratify the risk and specifically tell people that what you need to prevent your condition. So I think everyone in this room will agree to that because you're here for the Precision Medicine conference, right? AI actually started, we need to thank this Korean chess player Lee Se-do a lot because he is the only guy who ever beat AlphaGo on Earth, right? And now there's another version of AlphaGo called AlphaGo Zero. And AlphaGo Zero will beat AlphaGo any time of the day. and AlphaGo Zero actually has a much shorter training time and run on much fewer CPUs. So that's the future of physicians. I don't know, but anyway. So and it's not just doing chess. I mean, you can just say, oh, chess is just a game. So computer, we know the game. So what, right? There's another game called Texas Poker, which is not just a game of who's winning who, but it's a game of bluffing. Cheating, right? You have to lie, and then people have to buy your lie so you can win. And there's a computer program, there's an AI that actually beat every human poker player and won a $2.5 million US prize. Okay, so you can imagine the human are playing very hard. But we don't. When it comes to lie, we don't even lie better than AI. So AI can bluff better than human. That's not very good news. Anyway, so medical knowledge, we just talk about knowledge object. Medical knowledge can be very simple and can be very complex, just like the payload thing that we talk about, right? A logic like allergy to penicillin and then doctor prescribed penicillin. If this and this, we should stop the prescription and alert the doctor. That's a very simple logic that can be implemented in maybe just a couple of program lines, a couple of codes in knowledge object, right? But again, if you want to look at this, one picture and come up with the diagnosis of chronic radiation fibrotic dermatitis, that you probably need a lot more logic in the background. You probably need a convolutional neural network, CNN, in the background to actually recognize the picture and compare it against 50 million other skin photos. We know that melanoma, from this paper, melanoma using a dermoscope, the AI has outperformed human. That one we know on a specific. And also we know diabetic retinopathy using a fungal scope. The computer has outperformed human. Okay, so these are like the early days of computer playing chess against human, right? So computers are winning, and they'll keep winning for sure. We don't know how long that's going to take, but image is something that progresses very fast. Image recognition is something that progresses very fast in the AI arena. So I think that sooner or later, dermatologists like me is going to lose my job if our job is only looking at skin, right? And give a diagnosis. Or we can just press the button and we can go home. So anyway, so this compared to that, it's a very complex medical knowledge. Okay, so I have 5 minutes. So these are common algorithms that we use for AI. Among all these algorithms, rule-based, probabilistic, statistical, ad hoc, machine learning happens to be the most promising right now. One thing is because you don't have to actually care about the logic. They will come up with their own logic. The machine come up with their own logic, and you don't even know why. But it does the job. As long as it's winning, it's okay. And among machine learning, a lot of people are using artificial neural network. But this term is just too hard to understand, and so instead people calling it deep learning. So if you hear deep learning, it's actually artificial neural network, or a deeper artificial neural network. Okay, so but it doesn't. So they publish on Nature. Actually, this is AlphaGo paper, and there's an AlphaGo 0 paper also on Nature. So we come up with a lot of project that's related to neural network. Actually, our lab started to do neural networks since 1991, but at that time, no one cared and no one understand. And AI has a very bad name at that time. You know, AI equals, bluffing or something that's not real, or science fiction or movie, right? But again, recently we've been doing a cancer prediction project using ANN or the deep learning methodology, and we're able to just using the diagnostic code, we're able to predict hepatoma within a year, meaning the chance of this specific patient getting hepatoma in the next 12 months, we can predict it up to about 80% accuracy. So there are just different timelines. We call it a temporal prediction. So you can imagine that on the day the patient were diagnosed of hepatoma, the prediction will be 100%, of course, because you already know. But then you go back 1 week, okay, and use all the data. We use about 4 years of data. So use all the 4 years of data up to 1 week before diagnosis. We have about 90% chance, 90% accuracy. And then we go back all the way 12 months, we still have 80% chance of accuracy. Okay, so that's very exciting because we want to be personalized. We want to do precision prediction and precision prevention, right? We don't want to just one size fit all. So it's very important that we can do prediction. And so for the last few minutes, I'm just going to give you a little bit of my insight on Watson for oncology. I've been Watson for oncology. You know, Alan talked about how knowledge are sticky and leaky, right? And what he did not talk about was this water that's coming for you to wash, you put your hands into. This water is turning into a waterfall, okay? So it's not just sticky and leaky, it's flooded. I mean, you're flooded with water and you don't even know where to put your hands, because the knowledge that's published in all the medical knowledge will actually double in 73 days. That means after you graduate from medical knowledge, 2 months after you graduate from medical knowledge, your knowledge is only 50% useful, because the other 50% are totally new. And about a year, you have to learn everything again, okay? So it's not just that we cannot remember everything. It's the things that we need to remember are growing exponentially. So more bad news, you know, to people who rely on this tiny but very powerful brain. Anyway, so Watson does that for people that it reads a lot of papers, okay? So far, all the diagnosis of Watson oncology depends on literature. So if you ask Watson anything, it will say, okay, I recommend this because there's a clinical trial in this paper saying this. Okay, everything has to be based on evidence. There was a joke that some doctor posted a message on Facebook and saying, oh, I got this trial account with Watson Oncology and I type in a stage 4 colorectal cancer patient with brain meta and ask Watson, what would you do? Watson says, sorry, there's no treatment. Okay. Well, he didn't even say sorry. He just said no treatment. Okay, and this doctor was saying, see how stupid this AI is, and the AI is not going to help. But then all the comments below are, oh, somebody's speaking the truth. Right? Don't waste your medical resource and stuff like that. So, well, the good thing about Watson is it's not designed to lie, right? So it only speaks from evidence. But again, when all these senior oncologists, when they're talking to me, I told them, for the senior oncologist who's very familiar with all this treatment, especially medical oncologists, Watson has nothing to do with radiation oncology because it doesn't recommend anything about radiation. It doesn't recommend anything about surgery. It only recommends medication. So it's more relevant to medical oncologists. For very good medical oncologists, they don't have to worry about it for now, okay? Because Watson cannot go beyond medical literature. For things that's out of the literature, meaning very new drugs with very few clinical trials, they don't know what to do. So what is beyond the literature, the doctor has to improvise. The doctor has to, based on very few, just like we said, 75% of the time, the information are not complete. And doctors still have to do a diagnosis and make some treatment, right? So Watson cannot do that yet. But I told them, you will need it someday when you don't feel comfortable that you read 50 papers this week, but you missed another 5,000 papers, and that makes you uncomfortable as a medical oncologist. At that time, you will have to use Watson. Okay, so that's so much insight that I'm going to give to Watson. So we're using it in all our 3 hospitals right now for about 100 patients, but so far it's mostly just second opinion. Okay. So I think again this is actually from Chuck. Very long time ago, well, not very long time ago, about 8 years ago. So people are thinking that computer is going to replace human. But if AI do not stand for artificial intelligence, but rather augmented intelligence, then this will be the right model that, human brain plus computer greater than human brain. This model would actually everybody will agree with. So here comes again. So the doctor says, we have this Watson, it actually says Watson, supercomputer, and it's diagnose your disease, and the drugs are sent to your home by a drone. Then Dilbert says, well, it looks like your job as a doctor is becoming obsolete, right? The doctor said, no, you still need a doctor and a nurse to make the system work. The doctor go further and said, for example, somebody has to read the computer, right? The computer cannot read itself. And Dilbert says, actually it can. And then the doctor said, but the computer doesn't have a nurse, right? And Dilbert asked, what does the nurse do? Nurse come out and say, I stab him if he tries to do more than reading the script. Okay, but that's really totally useless. Anyway, so I told my our oncologist that if you don't work harder, this is going to happen. Okay, so we established a AI medicine and health innovation in TMU a while ago. So I think my conclusion is quite simple. If we don't use AI properly, we're not going to have precision medicine or quality and patient safety. And this IoT and big data is going to push AI to the next level. I think it's already happening. And AI has to change the future of medicine. Why is that? Because we deserve it. Thank you. Thank you.